Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fowden. I'm the chair and organizer of Grand Rounds, and welcome back after a summer break, which hopefully you've had some rest, some vacation, some break from things, and we're back into the program for the autumn into winter semester. We've got 3 talks lined up for this week, next week, and the following week. Then there's a bit of a wasteland in the program. So if you are watching this and think you have an exciting talk that you could give, please do get in touch so I can add you to the program. We've got basically every Thursday from the beginning of October all the way through to Christmas, currently empty. So if you are sat on a quality improvement project, some audit, recent publication, some interesting cases that you've seen in your clinical service, or a service update, or anything at all you think might be of interest to the general audience, please do get in touch and we can offer you a slot. And we welcome the diversity that of talks, which I really appreciate here at Grand Rounds, from our nursing colleagues, dentistry, particularly from students. And that brings us to the topic of today's talks. I'm occasionally asked by the medical school if we can dedicate Grand Round slots to our students, and I'm always delighted when that happens, because there's some amazing work that's going on in the medical school by some really talented people who are studying medicine here in Dundee. I'm going to hand over to Gillian, who I think is going to give a brief summary of what happens in the BMSc program, what our students are doing whilst they're taking a year away from their medical studies, why it's important and why it's so valuable to the students, but also to us as well, and enhancing and improving our knowledge of medicine. And I'd like to start to make a personal thanks to our 3 students for taking the time to come to Grand Rounds, for making their presentations. And at the end of all this, there will be a vote. There'll be a link to Mentimeter so the audience can vote to say who their favorite talk is. There's no losers here at Grand Rounds, but there will be a winner today. So we'll find out who has the favorite talk. Gillian, thanks very much for reaching out and getting in touch for this. I'm very pleased to offer you the slot here and looking forward to hear your description of what's about to come. Any questions, please put them in the chat and we'll get to them. There will be I think Shihab is going to field those questions and put them to our student speakers. Gillian, thanks very much.
Great, thank you very much, Tom, and good afternoon, everyone. Thank you very much for coming. I'm just going to share my screen, and while I am doing that, just say a few words of introduction. Can you see the screen share, Tom?
Not yet, Gillian.
Not as yet, no. So.
No, hold on a minute.
In the 90 seconds since you tested it, it has ceased to work, but I'm sure we'll get there.
It looks okay at my end. Let me try again.
Oh, that looks a little better. We can see your entire screen.
Excellent. And you're about to see my slide share. So while I'm sorting out the technology, I'd like to introduce myself. My name is Dr. Gillian Smith. I am one of the co-leads of the BMSc program in Dundee, and I'd also like to introduce my colleague, Dr. Shihab Kogali, who jointly runs the program with me. And many of you also know Julian Davis very well, who until his retirement over the summer was also a leading player in the organisation of the BMSc program. So many of you will be familiar with the BMSc program. This is an opportunity for mainly our own medical students to intercalate after their 3rd year of their clinical training. And I've shown on the slide here the 10 BMSc programs that are available to them. So you'll see the diversity of clinical interests that we offer to our students, where they have the opportunity to come out of clinical training for a year to really focus on something that interests them. And you'll see the course leads that do a fantastic role in helping us run this program. Many of you teach on this program, and many of you have been involved in supervising our students in their research projects. And we are very grateful to you all for doing that and for your ongoing support. The research project is particularly important today because it forms a very large part of all of the BMSc courses. all of our BMSc students carry out a project that's typically 10 to 12 weeks long, and they really develop a project themselves in something that really excites them. So that brings us on to the focus of today's presentation. And to tell you why Sir James Mackenzie is important, just some brief words of introduction to this very eminent physician, a local doctor born in Scone, completed his medical training in Edinburgh, and then was a GP for 25 years. So a slightly unusual clinical career. He developed an interest in cardiology during his work as a GP, and then very quickly became recognized as a very eminent cardiologist with a specialist interest in cardiac arrhythmias, to the point that between his progress between 1907 and 1915 led to him being knighted for his work and elected as a fellow of the Royal Society. And again, quickly after that, as he headed to retirement, he was the founder of the Mackenzie Institute of Clinical Research in St Andrews. And you'll see Sir James Mackenzie commemorated and highlighted in our own medical museum in Ninewells. He's therefore a very apt, it's very apt and appropriate that we have named the Sir James Mackenzie Prize in his honour. And the Sir James Mackenzie Prize is awarded to the BMSc student who completes what we judge to be the best research project each year. So each of our 10 courses has their own individual assessment, and each course nominates their best student to compete for the Sir James Mackenzie Prize. So as Tom said, there are really no winners. The winners really are all of our 10 students who are nominated. We held a session last week where we listened to all 10 presentations, and the students who will be talking to you today were judged by a diverse panel of judges to have given the top 3 talks last week. So I'm going to hand over to Shahab, who's going to introduce the students to you. They're going to present in alphabetical order. And then finally, just to remind you, as Tom has mentioned, we're really hoping that you will all join us in helping us to identify the best presentation today. I will reshare the Mentimeter code at the end of all 3 presentations, and we hope that you can stay online with us long enough to vote. And Mike Latto from the Medical School Office will join us at the end of the meeting to tell us who our winner is. So without further ado, I'd really like to hand over to Shahab and to the first student presenter.
Can you bring the last slide, please? The slide before this, Ilya.
Yep, of course.
Thank you very much. So we got 3 presenters today, as Killian said, and we are just going to do this presentation in the order which is shown in the slide. And each presenter has 10 minutes to do their presentations, up to 10 minutes. So I'm going to switch my camera once you started talking. I'm just speaking to the students now. And when I switch on my camera, that means you are now 9 minutes and you only got only 1 more minute to speak. And I will stop you at 10 minutes if you go beyond that, but hopefully you will all abide by time today. So I'm looking forward to the 3 interesting presentations this afternoon. So the first presenter is going to be Callum Selcock, BMSc International Health. And the title of the presentation is going to be Navigating a Perfect Storm, Factors Affecting Primary Care Management of Adult ADHD. So Callum, the stage is yours now.
Thank you very much, Shahab. And just to remind the audience, it would be great. We should have time for a couple of questions for each student after their talks. So if you could think of some nice challenging questions for the students, that would be great. Thank you very much, everyone.
Thanks, everyone. Hello. I will share my screen with you just now. Okay. My name's Callum. As you heard, this project is called Navigating a Perfect Storm, and it's to do with management of ADHD in adults in primary care and how that interacts with management in secondary care. So really, this is what I'm going to tell you this afternoon. Probably the most important point to highlight here is just a reminder of what ADHD is.
Callum, we can hardly hear you. I don't know if that's me or that's everybody.
You can't hear me very well.
I can hear you, Callum, but if you could get a little bit closer to the microphone, that would be great. Thanks.
Your voice is a little bit distant. Sorry for that, Callum.
Yeah, no problem. I have a pair of headphones with a microphone. That might help. Is this any better just now?
Yeah, that's better. Thank you.
That's better. Okay. So as I was saying, the important point to highlight here are that ADHD is three of inattention, impulsivity, and hyperactivity. Crucially for this group, in which are adults with ADHD, the symptoms have to have been present before age 12, and that's according to the DSM-5 and the most recent ICD-11 criteria. Okay. So we'll start off with a question. In Scotland, which NHS board do you think prescribes the most ADHD medications to adults? You might want to think about the size of the urban area, or maybe the age of the population, where the most universities are, and so on. The answer to this question is that NHS Tayside, perhaps surprisingly, proportionally prescribes more ADHD medications to those aged 16 to 65 than any other health board in Scotland. And here's the data to show that. So not only does Tayside prescribe more of these medications to adults, but this prescribing is increasing, and increasing by quite a lot. So the data that we accessed before starting this project was that between 2010 and 2020, this increased by 300%. So that was quite surprising, and that definitely got us scratching our heads. So this is the first bit of information that we knew before starting the project. The other part is how, and I should tell you this, is how prescribing works between primary and secondary care for ADHD in adults. So there's a shared care agreement. What happens is a patient might come to the GP and say that they've been suffering from these symptoms. And at that point, the GP can then refer them to psychiatry. In the secondary psychiatry service, the community mental health team may diagnose ADHD and then may recommend a treatment to be prescribed by the GP. So it's the GP that's prescribing the treatment. The psychiatry service is recommending it only. So what I've told you so far is what we knew before starting this project. So I've told you a bit about the statistics and about the systems that are in place. And of course, this raised some questions for us. So because GPs have such a large role in this, it was really important to find out what they thought was driving it. Then it was important to find out and see what we can glean from what GPs, what psychiatrists told us, to see whether it's the GPs themselves that could be driving this increase. So we had these questions, we knew the information that I've told you just now, and we decided that the best way to find this out was with qualitative study. So what happened was there was a research team. It was myself and two psychiatrists, Dr. Thomas Lung and Dr. Stefan Kloss, excuse me. And we formed a research team in which we gathered data using semi-structured interviews. There was 10 interviews with GPs and 2 interviews with psychiatrists. Each was about, I think our average was 37 minutes long. So if you think people speak maybe 60 to 100 words a minute, this is quite a lot of data that we had. On this data, that we then performed a framework analysis, and this allows researchers to individually and then collaboratively identify themes and trends in the qualitative data, which built towards our final synthesis. So this just tells you a little bit about the sample of GPs, which is probably our most important sample. So as you can see, we've got a wide range of ages, of levels of experience, and then the GPs, the practices that they worked for themselves, had a range of levels of deprivation and of sizes. Also, interestingly, in this group of GPs, we had GPs with personal experiences with ADHD, and they discussed those in our interviews. And then we had perhaps the other end of the space of opinion, some GPs who were quite cynical, and that's their own words, of the diagnosis generally. So I've told you about the methods now of the study. We used the qualitative analysis and framework analysis, and our questions really were to find out what's driving this increased prescribing, how is it happening? So what did the GPs actually say? Well, here's a few quotations that we heard from the GPs in the interviews. As I told you, there was 10 of them. So this is really just a little sample of what we heard. So this first quotation kind of highlights the international link to this in this presentation. There was a bit of discussion around whether through cultural means, increasingly patients are suspecting that they will fit a diagnosis of ADHD. Then we heard about a stretched psychiatry service with long waiting times, and we heard about high levels of locums and poor continuity of care. Then GPs told us that they weren't really familiar with how to manage this condition in adults. They weren't really familiar with how to monitor the medications. So that it hadn't been part of their training. It wasn't something that they had learned about. Even the GPs with a particular interest in psychiatry, who had attended psychiatry conferences and extracurricular psychiatry activities, they weren't particularly familiar with it either. So there isn't really the training there. So what I've told you there fits into this diagram that I created based on the what we heard from GPs rather, and it was corroborated by the psychiatry side of things. So the general trends on the left-hand side. So it seems like a lot of patients are suggesting the diagnosis of ADHD to their GP, not vice versa. There's also an element of secondary gain, and it's not necessarily seeking drugs or medications, but patients seem to seek a diagnosis of ADHD for the perceived extra job security, for things like extra time in exams, and for financial support as well. On the point of demographics, deprivation seems to have the most effect on the likelihood to present with symptoms of ADHD. GPs suggest that deprived patients are probably more likely to fit a diagnosis of ADHD, but they're less likely to get it. And that's through a myriad of factors: their social situation, what actually they see as important, and then their level of engagement with things like tertiary education and more difficult managerial type jobs, which GPs discuss. Patients come to see them asking for these medications to help manage. Then the point we touched on earlier on, there's more awareness generally of ADHD. It's in the media more, it's on television, it's on social media, and also because more people are being diagnosed and treated for ADHD, this begets more diagnosis because everyone is more likely then to know somebody who has been diagnosed with the condition. Then to discuss the psychiatry service, in all areas it's stretched, as I said, more locums and longer waiting lists, poor continuity, and so on. Then in the area of shared care, GPs say that the monitoring isn't clear and they aren't monitoring patients who have been given these ADHD medications. We'll discuss that more in a minute. And they also had some concerns about misuse and diversion, but these were more sidelined compared to some of the continuity of care type worries. Overall, this leads to an increased number of patients seeking private care services where they can afford it, and really to a more inequitable system of treatment for individuals with ADHD. So then our corroboration with interviews from psychiatrists, what did they say? Well, for the most part, they corroborated and agreed with what we heard from GPs. So they said that they're seeing more patients with ADHD. These patients are influenced by social means. And across both groups, there was a tendency to prefer non-pharmacological treatment. This is their ideal, but there aren't the resources to offer this to patients. Then, and this is a really interesting and important point, psychiatrists I spoke to were clear that they aren't monitoring patients that are taking ADHD medications long term. They expect the GPs to do that. So this leaves us with a bit of an interesting question. If the psychiatrists expect the GPs to do it, but the GPs are expecting the psychiatrists to do it, then is it being done at all? Who's monitoring these patients? So this is what I've told you just now. This is the themes that we've gone through. Now, you might find yourself maybe at this point in the presentation thinking, well, does that really matter? Does it matter that these patients are being given these medications long-term, which do seem to improve some of their symptoms? Well, I'll draw your attention to these two papers. The first one very impressively showed a safety level for these medications with a network meta-analysis. But actually, when you look at the protocol for this paper, there was a subgroup analysis at 26, 52 weeks, and a subgroup of analysis of papers not sponsored by the pharma industry. And these were all withdrawn. So really, this paper only relates to 12 weeks after initial treatment. Again, this paper at the bottom, I'll just show you, was actually withdrawn from the Cochrane library because of concerns of conflict of interest. So there's really big pharma interest in this area. Again, because there isn't a defined endpoint to treatment, so if you treat a teenager or a school student with ADHD with a medication, you've got the summer holidays, you've got exams, at that point you can stop the medication. This doesn't really exist in adulthood because what you have is you're taking this medication for a long time for your job. So what do we think should happen next? It would be good to have more GP training, more multidisciplinary management, and it would be good to share data between primary and secondary care. In terms of more research, it'd be good to quantify the level of private prescribing. It might be difficult, could do it with a patient survey. It would be good to know actually what monitoring is happening, and then it would be good to know, compared to other health boards, what's happening in Tayside to see if there are things specific to this area. So thanks very much. If you want to see the full work, it's in that QR code.
Thank you very much, Callum, for being on time. So any questions, please pop it in the chat, and I will just read that for Callum to answer.
Callum, I'll take chairman's privilege here and ask you, the Tayside has the highest rate of prescribing of these drugs. Does it have the highest rate of the diagnosis? Because you, as you said, you only limit medication to the people who need it. And as a follow-up to that, do you have any explanation why Tayside has the highest rate of ADHD in the country? I know you've been into the demographics of it, but why particularly? What is it particularly about Tayside?
Yeah, interesting question. Thank you. So, in terms of levels of diagnosis of ADHD, this is interesting. I don't have the exact data on that on hand. What I understand from talking to GPs is that there could be some element of this, which is a legacy from CAMS diagnosis, so from childhood diagnosis of ADHD. So individuals that might have been diagnosed with ADHD as a child who have now reached that adult point. So there might be some element of that. I heard stories that previously in CAMS and in paediatric services in Tayside and in NHS Fife, individuals were diagnosed at a young age in a sort of one-stop shop. So they were seen very briefly by a professional, and then this label of ADHD was applied to them, which then stays with them through as they age. So there was questions around whether actually this diagnosis is accurate or not. In terms of actually why it's different in Tayside, or why it's bigger in Tayside, this is interesting, and the population is quite similar to the rest of Scotland. There doesn't seem to be any particular differences in terms of demographics or in terms of a rural and urban mix. So I think the reason for increased or potentially increased levels of ADHD is that maybe the services are diagnosing it more.
And Callum, I think that's an interesting point you make, because somebody in the chat has said that Fiona Robertson has said that from personal experience, Tayside has the shortest waiting times for assessment. You see more people, you get them done quicker, you're likely to make more diagnoses. So I think you make a very pertinent point. Thank you very much. I've enjoyed your talk. It was excellent.
Thank you.
Thank you very much. I think we need to move on the interest of time. So the next presenter is going to be Hannah Berry, BMSc Applied Orthopedic Technology, and talk is entitled Investigating the Biomechanics of the Freestyle Stroke in Swimming Using Field-Based Wearable Technology. So the
Thank
stage is
you.
your, Hannah, now.
Okay, I'll just share my screen. Okay, so I hope everyone can see my screen there. So good afternoon, everyone. I'm Hannah, and I'll be presenting on the biomechanics of the freestyle stroke in swimming using field-based wearable technology as part of my BMSc thesis. So as a bit of an introduction to the sport of swimming, and in particular the freestyle stroke, swimming is a cyclical motion of coordinated and synchronous actions of the trunk and the limbs. And in competitive swimming, there is a strong focus on enhancing performance and reducing injury in training and competition through optimizing the stroke mechanics. And comparable to the gait cycle in walking, the arm motions in swimming can be represented by the stroke cycle, which uses the position of the hand relative to the body or to the water surface to identify 4 distinct phases. The pull phase and the push phase are the propulsive phases of the stroke. To date, the video-based systems have been the mainstay for monitoring and analysis of swimming, and our current knowledge is very much owing to employing these methods and using the video-based systems mostly. However, they do pose several limitations. Some other existing technologies that have been used have included some lab-based simulation and analysis, tethered swimming, and in flumes or endless pools. Recent years, however, have shown a significant rise in the interest of inertial measurement units, or IMUs, in various activities such as running, walking, jumping, and now the interest is growing in the field of swimming. And so the aim of this study was to explore the biomechanics of freestyle swimming using field-based wearable technology in the pool-based setting. And so the objectives we set out to achieve this were to analyze the characteristics of the stroke at a low to moderate training speed, and then again at a faster speed. And also importantly as well, to provide a perspective on the potential use of the system for future biomechanical research and the in-field application of this. So there's specific kinematic variables that have been of swimming performance that have been shown to correlate to competition success. And this includes the swimmer's average velocity, the stroke rate, and the stroke length. And as well, a term called the stroke index has been considered as an estimator for overall swimming efficiency. So for this study, we recruited 10 experienced swimmers, and they completed 2 100-meter freestyle swims. The first we called condition 1, which was at a low to moderate aerobic intensity. And then the second we called condition 2, which was at a higher maximum intensity. We utilized Vicon's latest implementation of inertial measurement units called the Blue Trident system, and it's a 9-axial IMU, which incorporates an accelerometer, a gyroscope, and a magnetometer. We used 3 IMUs for each participant, and they were positioned on the right wrist, the left wrist, and the lower back. And we orientated the axes as I've illustrated in the images here. And so the next few slides will just help to illustrate a bit how we were able to detect a number of the events using the sensors on the wrist and the back, and how we use this for further analysis. So firstly, this chart here is the signal of the forward acceleration from the lower back IMU, and we could detect the start of each swim and of each lap, the glide phases of the wall, the swimming phases, and the turns at each length. And this was from one full 100-meter swim. This chart here is from the right wrist acceleration, and it's cropped to show 2 complete stroke cycles. And here we could identify the 4 distinct stroke phases. So the entry and catch, the pull phase, the push phase, and the recovery. And this chart is from one 25-meter lap. And here we could extract the stroke count and the time from when the first stroke began and when the last stroke ended. And finally, this chart here is from the lower back gyroscope sensor of the degree of rotation about the longitudinal axis of the body. And here it was hoped that this would allow us to visualize and to quantify the body rotation of the swimmer, which is quite an important aspect, especially in freestyle swimming. However, we were unable to use this function as it was restricted by a phenomenon called a gimbal lock, and it prevented us from interpreting the axes. So we could then calculate a number of the important primary kinematic variables, which I've listed here. And using this data, we were able to show some results. So there was a statistically significant increase in the average swimming velocity when the participants executed their swims in condition 2 compared to condition 1. And as well, there was statistically significant an increase in the median stroke rate, as well as decreases in the median stroke length and in the average time per stroke in condition 2 compared to condition 1. There was also a strong negative correlation between the stroke rate and the stroke length, suggesting that an increase in the stroke rate during the swims was strongly associated with a decrease in the stroke length. These results provide a basic kinematic analysis, of the primary kinematic variables of swimming at 2 different swimming velocities. And the findings acknowledge the potential opportunities for further use of IMUs in the swimming and in the training environment. However, it is important to recognise the limitations of the study and the use of the IMUs. As I mentioned, we were unable to utilise the global angles output from the gyroscope, which did have great potential in providing information on body rotation angles, in patterns, and in coordination. The study also did not account for the great individual variability in swimming, and so future work should take this and other factors into consideration here. One of the strengths, however, included that the data was successfully collected in the ecologically valid setting of the pool in this situation. And the IMUs also provided the ability to collect the data on 1 or more participants over a greater distance. Despite the increasing amount of work on IMUs in swimming research, the use of this technology in the real in-field assessment is still at the beginning stages. With further research, IMUs do have the potential to explore and provide insight into an extensive array of parameters, as I've listed here. So in conclusion, it's offered that this study does constitute a valuable addition to the novel approach and the growing work surrounding IMUs in the pool-based setting. It's suggested as well that their use in conjunction with the video-based methods that we have used as a gold standard for quite a number of years now may provide significant improvements in the knowledge that we're able to be achieved, and also to be utilised and deemed as an easy to use and an operable tool by coaches and athletes, and not just by researchers and biomechanists. The system does require further development. Importantly, however, this technology is still in its infancy, and the study does provide a perspective on the use of the IMUs in the ecologically valid setting, and it's with an activity that is so vastly popular worldwide. Thank you, everyone, and I'm happy to answer any questions.
Thank you very much, Hannah, for another excellent talk. So, any questions, please? Chairperson, do you want to take your advantage again?
Yeah, thanks very much. Let me just put my camera on, so not just a disembodied voice. Hannah, lovely. I've done my fair share of lengths up and down a pool, and know my stroke is terrible. So this is a really nice way to demonstrate how terrible it is. Down the line, do you think there's any scope for reporting? So is there a way to get AI to tell you how bad you are and why you're bad and how to improve? Or is this just going to spew out data and relies on a coach to be able to tell you what to do with it?
Yeah, so that was one of the things I did actually think about, and I think it does, this kind of system, I think is definitely provides like a basis, for a foundation to build on, and with all the technology coming out now and the like software engineers, and I think getting a lot of that kind of system building involved, there'd be a lot of potential for like self-athlete led kind of things, so apps and kind of software that you can use in a user-friendly manner, so that it's not just someone at the side of the pool churning out numbers and data that doesn't always mean too much to a person who just kind of wants to visualize things and kind of more have an answer rather than just numbers and data that might mean something completely different to each person. And so I think definitely, like, the technology these days, it does provide a good basis, I think, to be incorporated into apps and other systems that a single person could use in their.
You tested this on at different velocities, which is obviously important. Did you test it at different abilities? Did you get, like someone who is swimming at an elite level and someone who's like me, just chuntering up and down? And were you able to see, was it obvious the differences between stroke and technique and rotation and things?
So we for this study we used but there was a group of athletes who train quite a lot every day, and they have quite a long history of training and competition to quite a high standard. And I think we did that. I did think about comparing kind of two different groups of swimmers and abilities and experience, but I think for this, just because it was kind of a start, it was best to kind of keep it at the same level there. But it is another kind of way that you could use the system and look at the different, what kind of data you get from different experiences and abilities. And as well, there was obviously differences in, the speeds of the swimmers and their stroke, and the rates that they were putting out in my trials. And so you were able to see the differences there, because there were some athletes who were sprinters, and there were some who competed at much longer distances. So albeit they were similarly experienced swimmers, they had completely different abilities with their sprinting and speeds. So we were able to see that that kind of thing as well. So yeah, there's definitely scope for.
It'd be fascinating, I think, to get the traces from the sprinters, the long distance, elite, interested amateurs, novices, and then blindly give them to coaches.
Yeah, that would definitely be interesting.
Is it feasible? Can you detect, obviously, or what are the things you can see on the traces that point you towards being excellent? In running, we collect a huge amount of data like ground contact time and cadence and all these different bits and pieces, but no one really knows what to do with it. It's just numbers. So it would be very interesting to see if that translates here, or whether there is actually an optimum Mr. Smooth that you should need to follow. Again, lovely data. Really enjoy your talk. Thank you very much.
Thank you.
Thank you very much. So the last talk then is going to be by Sophie Baird from anatomy, and the presentation is entitled Natural Orifice Transluminal Endoscopic Surgery, a Transvaginal Appendectomy in the Surgical Management of Acute Appendicitis.
Perfect, thank you. Hopefully you can all see that screen. So good afternoon, everyone. My name's Sophie Baird, and I completed the Anatomy BMSc last year. And my title is Natural Orifice Transluminal Endoscopic Surgery, the Transvaginal Appendectomy in the Surgical Management of Acute Appendicitis. So just to give a bit of a background, firstly about appendicitis. So as I'm sure you all know, appendicitis is the inflammation of the vermiform appendix requiring immediate surgical removal. So as you can see from this diagram here, the appendix is situated at the end of the cecum, just inferior to the ileocecal junction. So appendicitis causes an acute abdomen, and this is the most common surgical emergency that we see. So patients have a 1 in 15 lifetime risk of developing appendicitis, which means that a safe and effective way to remove the appendix is really important to ensure the safety of many patients. So the current procedure that's done to remove the appendix is the laparoscopic appendectomy, and this replaced the conventional open appendectomy. So this procedure is used in all cases except for pregnant patients, And as you can see from this diagram here, there are either 2 or 3 incisions made in the anterior abdominal wall, and instruments are placed through these incisions and the procedure is carried out. As you can see from these 3 statistics here, the LA is a very successful procedure with minimal complications. So my research focused on the notes appendectomy. So natural orifice transluminal endoscopic surgery allows surgeries to be completed through a natural orifice, which means that there's no anterior abdominal wall scar left on the patient. So for the appendectomy, this can be done transgastrically, so through the patient's mouth and making an incision in their anterior gastric lining, or for what I focused on, it can be done transvaginally. So as you can see from this diagram here, the incision is made in the posterior fornix of the vagina, with the cervix being retracted anteriorly. This can be done using pure techniques, which means that the entire procedure is carried out through this incision, or it can be done hybridly, meaning it's carried out through this incision with one additional trocar in the abdomen. It can be done using rigid or flexible tools, and currently there's strict guidelines for the selection of patients for this procedure. So in terms of the aim of my project, I wanted to assess whether the transvaginal appendectomy could in time replace the laparoscopic appendectomy as the mainstay of treatment for acute appendicitis in female patients. I focused on the entire patient journey from start to finish, starting with mean operative time, intraoperative complications, moving into the postoperative period, so postoperative complications, pain levels, and sexual function and fertility following this surgery. I then discussed patient and physician perceptions about the 2 different operations and finished with discussing mean length of hospital stay. In the interest of time today, I'm just going to discuss these 2 highlighted in blue, so mean operative time and patient and physician perceptions. So in order to do this, I did a literature search on PubMed and using the Dundee library search tool, mainly aiming to find primary sources with primary data, but used a few systematic reviews as well. So the first main finding that I'm going to discuss is mean operative time. So I found that the transvaginal appendectomy can be completed in equal or shorter amount of time than the laparoscopic appendectomy. I also found that there was, with increasing experience of surgeons and centres that were performing this surgery, that would shorten the operative time. There was a bit of contention in the literature surrounding whether it takes longer to do the pure procedure or whether there's no difference, but it was found that using rigid tools is faster than using flexible tools. As you can see from this diagram here, this is the setup for the transvaginal appendectomy. This is an excerpt from one of my tables. I just want to highlight here that the centre that did the least number of procedures here had the longest operative time, and the centre that did the most number of TVAs had the shortest operative time. So my second main finding that I'm going to discuss is surrounding patient and physician perceptions. So notes has kind of been pioneered as a scarless surgery, and that has been promoted as the main benefit is that there's no scars on the anterior abdominal wall for patients. So looking at a couple of articles here, so it was found that 50% of patients would prefer notes over the laparoscopic surgery, but they mainly were concerned about postoperative pain. They were encouraged that there was a lower amount of pain in the TVA and there was a reduced risk of hernia. But cosmetic outcome, surprisingly, was actually only an interest in 30% of patients. Another article showed that the majority of patients aren't actually concerned with abdominal scarring, and most patients are very happy to undergo a transvaginal surgery. In contrast to this, I found that physicians, only 21% would prefer notes over the TVA. They were concerned about infection and the fact that notes is quite an under-researched surgical avenue. And they were more concerned about the transvaginal access and were more assured by laparoscopic surgery as an access route. I thought this was a very interesting thing to find out, as I would have assumed that patients would be very concerned about the cosmetic outcome, and whereas it seems that physicians are actually much less susceptible to wanting to do this surgery rather than patients receiving it. I think it's always important to identify limitations of any research that you carry out. So I've listed a few of those here. I just wanted to draw your attention to the sample sizes. So this is an excerpt from one of my tables. I just wanted to show you that this procedure hasn't been carried out very many times. So my conclusions are limited by the small numbers of patients that this procedure has been carried out on. So in terms of my conclusions, the transvaginal appendectomy is a safe and effective alternative treatment to the laparoscopic appendectomy for the treatment of acute appendicitis. It's a quick procedure, it's safe, there's minimal complications intraoperatively and postoperatively. Patients have a reduction in pain following this procedure. They have shorter hospital stays, and there's a low rate of long-term adverse effects, including on sexual function. I believe that this procedure could be widely utilised due to the prevalence of appendicitis in the general population, but I think the biggest barrier at the moment is the physician doubt that still exists. So finally, I just wanted to highlight a few avenues for further research. There's quite a few of these, as notes is quite an under-researched surgical avenue, as I've discussed before. But I just wanted to highlight this first one here, exclusion criteria. So as I said in my background, currently there's quite strict exclusion criteria for patients to make sure that the best patients are chosen for this procedure. And I think a wide-scale study to find out whether it would be very useful to find out whether the number of patients for which this procedure is suitable is enough to warrant and justify the cost and the time and effort that it takes to equip the surgeons, to train the surgeons, and to equip the centres to be able to perform this procedure. So I've just added a few of my references here at the end in case you'd like to research this any further. Thank you very much for listening. I'll be happy to take any questions.
Thank you, Sophie, for another excellent presentation. So any questions to Sophie, please?
Thank you, Sophie. I have to say, when I got the titles, this was the most intriguing of them. Now, a couple of questions. You skirted past the sexual function issues, which is the thing that I'm sure crops to many of our minds. So could you perhaps just give me a elevator pitch on the sexual complications?
Yes, of course. So as I was talking about with exclusion criteria, some of the centres refused to perform procedures kind of on younger patients that would be wanting to have children in the future and that sort of thing. But from the data that's available at the moment, it seems that there's no complications postoperatively in terms of sexual function or fertility. I also discussed, obviously the sample sizes for this procedure are quite small, but I did look also at the notes cholecystectomy that's done transvaginally. So I looked at kind of the complications in terms of the gynecological part of the procedure for the cholecystectomy, and the outcomes are very positive. It seems there's very few postoperative complications. There's no kind of pelvic pain. There's no change in sexual function, no change, and they had lots of different parameters that they asked patients about, and there was preliminarily no issues.
And one of the things I've learned as the further on I go in medicine is to stay in my lane. And perhaps I don't do that as much as I should, but who's doing this? Is it gynecologists? Is it general surgeons? What's the training process? You know, I don't go below the diaphragm. That's one of the rules. So for the surgeon, they're venturing into unknown territory down there.
Yeah, so it's general surgeons that are performing this procedure. And I think a lot of the training is that the gynecologists do perform this incision quite regularly. So I think they would be teaching the general surgeons how to do it. And some centres said that they wanted a gynecologist present. So the gynecologist did the incision and then the general surgeon did the appendectomy. Which I think for those centres, they found that was potentially quite difficult because that's then having an extra surgeon present. But some centres just had the gynecologist train the general surgeons, and then the general surgeons just carried it out themselves.
Excellent, thank you.
Better pain outcomes is a big plus. How long was the follow-up?
Sorry, I'm struggling to hear you there. I don't know whether it's just me or.
So how long was the follow-up? This is a question. So because the comment is that better pain outcomes is a big plus, but how long was the follow-up?
Yeah, so I think, so for the pain outcome studies, there was 2 different studies that were done that I looked at. The first one actually looked at the patients when they were in hospital, and they compared the patient's use of their morphine pump while they were in hospital. And the patients with that had the transvaginal appendectomy used their morphine pump less than the patients with the laparoscopic appendectomy. And then another paper that I looked at, they followed patients up until 6 months, and they asked patients about their pain levels, and it seemed very overwhelmingly that the transvaginal surgery had less pain than the laparoscopic surgery. Yeah.
Okay. Thank you to the 3 speakers. I think we are on time, and we've got time now to do the voting as well. So thank you for the 3 excellent presentations from the 3 students. I'm going to hand over now back to Gillian and Mike, who will manage the voting for who is going to win the prize this afternoon. Thank you.
Yeah, thank you again to all the students from me as well. And thank you to Tom, who has very helpfully added the Menti code into the chat, but I'm sharing it again now. So we would really appreciate everyone taking a couple of minutes to log into Mentimeter, use the access code, and within there you should see the 3 students listed, and we would like you to just simply vote for the presentation that you found most interesting and enjoyable this afternoon. So if you could do that now, hopefully Mike will be working his magic in the background, and we should be able to reveal the winner shortly.
Whilst everyone is doing that, I'll just put in a bit of plug for the rest of the Grand Rounds semester. Next week, Craig Mowat is going to present on an update on fecal hemoglobin as a predictor of colorectal disease in the symptomatic and screening populations. So this is fairly topical. I don't know if you hang around on YouTube very much, but Ryan Reynolds and Rob McElhaney, who are the chair people of Wrexham Football Club incongruously, posted a video this week of them both getting their first screening colonoscopies because they're 45, looking for bowel cancer, which is what happens in America. If once you're 45, you get an annual colonoscopy. We don't do that, and Craig Mowat is going to explain to us what we do in terms of fecal hemoglobin testing to predict colorectal disease. And don't forget, Tayside is the National Centre for Colorectal Screening, of something that Professor Bob Steele was fundamental in setting up for his retirement, and our biochemistry department do a huge amount of work on that. So that's a really important topic to come to. And the following week, I have who do we have? It's the Sustainability Group, and Dr. Sharon Flagler, I think it's Flagler, is going to talk on a topic as yet unclear, but the Sustainability Group have sorted that out. After that, there is a spare week, and then there's the DCAT lecture, which you should have got information about already. As I say, we've got loads of free spaces, so please do get in touch if you've got to talk. Either that, or you end up with me talking about respiratory diseases again. So please do get in touch. If you've missed any Grand Rounds, then please go to our YouTube channel and you can see Grand Rounds all the way back to 2015. There are some gaps here and there, but I do spend my spare time editing and uploading previous videos back from the depths of time. And if there is a specific Grand Round that you have missed that isn't there, please do get in touch and I'll try to prioritize it from the list. So I think the voting is finished. So I'll hand back to Gillian, who hopefully will reveal the legend, as they say.
Yeah, I think we're actually sharing Mike Lattle's screen now, so I'm hoping he can press some magic button if we start a slow drum roll. Oh, it's very tight, but I think we have a winner. So before we congratulate Sophie, I'd just like to reiterate what I said at the beginning, that all 10 of the students that were nominated are definitely winners in their own right. These 3 students have done particularly well as they came through our first round last week. And I think it's actually really appropriate that there's very little between any of the presenters today. Your talks have all been recognised by the audience. But we have a winner, and the winner is Sophie Baird. So congratulations, Sophie, from all of us. And we will be in touch later this afternoon for what happens to allow you to more officially claim your prize. But well done to all three of you, and particular congratulations to Sophie.
Just add my voice, congratulations to all, and congratulations specifically to Sophie. And
we finished before 2 o'clock, which is miraculous. Yes. So well done, everyone, for giving us time. And thank you very much to Tom for allowing us to take up one of his Grand Round sessions.
You're more than very welcome, and it is really nice to hear our students speak. I think it's a testament to the medical school and the BMSc courses that you can speak so well and so clearly on these topics, and to you for stumping up to come and do it. To the three students, it's an intimidating environment to come and speak to everybody, and so well done. Not a hint of nerves. Very professionally done. Well done.
Fantastic, thank you. Do book us in again, sort of same time next year, Tom.
I shall pencil you in immediately. So if you are a student watching this, or a student or watching it on YouTube, and you think you could do just as well or better, then please get in touch, and you can have a slot. We're open arms to absolutely everybody. We are back next week. I've said already, it's Craig Mowat talking about fecal hemoglobin testing, and I hope some of you will get in touch to offer slots for later in the season. Enjoy the rest of your day. Have a good weekend. See you again next week.
Thanks, everybody.
Thank you. Bye now.